Can you please tell me, describe what you see?
I see a child and who has got red lips. There's rash on the cheeks and there's a picture of a throat which is erythematous throat, and there's a characteristic strawberry tongue also noted. Uh, and there's a um, widespread macular erythematous rash that is seen. So, my differential diagnosis would be a child with a streptococcal throat infection.
Or what are the DD you can keep? Other?
So, it can also be Kawasaki's disease. It can also be any other viral exanthematous infections.
So in this video, I can see a child who probably 4 to 5 years age old. Child is like average for age. There is no any device attached. We need to comment all these. There is no
Okay.
device attached. There is no any device attached. No distress. We can say. I see some. There is lips are like red lips, strawberry tongue. Uh, there is a rash on the cheek, but it is avoiding the side of the mouth. There is sandpaper like rash. The rashes are sandpaper like, and throat is also infected. So it is a case of scarlet fever, and the DD can be Kawasaki disease, meningitis, Hennesculin purpura, ITB, SLE. SLE you can keep that. SLE there is malar rash. So it is a caused by bacterial infection, group A streptococcus. What history we like to ask?
So I would like to take a complete history of onset, course, and duration of the symptoms of, especially if there's associated fever, and any systematic infection in CNS symptoms like any lethargy, fatigue, and any signs of raised intracranial pressure, vomitings, early morning vomitings, any other signs like running nose, ear infection, any cough, and how long, if there's any cough, how long is the duration of the cough. Then going to GI symptoms like any vomiting, any diarrhea, and
Okay.
musculoskeletal symptoms as well.
Okay, I'm telling. When we take the history, we can keep some that what we see in this video. Our diagnosis and the differential diagnosis we keep together. Then it's easy to take. First, as usual, onset, course, and duration. What make it better? What make it worse? As rash there is. So rash, some history asked. So the rash when started. What is the distribution of the rash? It is oozing, blanchable or non-blanchable, itching, non-itching, painful, painless. Okay. So we keep Kawasaki disease here. So Kawasaki disease, that strawberry tongue, conjunctivitis present or not, any peeling of the hand and the finger, edematous finger. These are Kawasaki. Any swelling in the body like lymphadenopathy. Kawasaki we are keeping as rash. So contact, similar contact occur in the patient. Fever, weight, activity, sleep. So meningitis also associated with fever is very important. Weight, activity, sleep. Then the vaccination status we can keep here. Any chronic condition as SLE also associated with rash. Any chronic conditions, a family member has similar conditions, like clear. And also we know scarlet fever, one of the complication group is streptococcus pharyngitis, that is rheumatic fever. So rheumatic fever features we are asking: any palpitation, chest pain, cola colored urine, personality or behavioral changes. Clear?
Yes.
Okay. So what investigation we do?
So investigation, firstly, bedside investigations, and then lab. So assess the ABC of the patient, and then do bedside vitals.
Investigation, not examination.
Okay, investigation. So essentially, full lab investigation, full blood count, and CRP, and if to check for hydration status, renal function tests, um,
Okay.
and and
Yes.
throat swabs as well.
Culture. Hmm, very good. So we can keep like a full blood count. Yes, we can keep. Child is infectious or non-infectious. Yes, that's CRP, C reactive protein. Okay, keeping throat swab cultures. Okay, And the complication we know rheumatic fever, so ASO titer test and anti-DNS V. Okay.
Yeah.
And examination, what we do?
So complete physical examination, general physical examination to look for more rashes, and do a complete respiratory examination to look for any pneumonias or any chest symptoms. And if we are suspecting rheumatic fever, do a cardiovascular examination as well, and neurological examination to assess the GCS of the child as well.
Actually, respiratory examination not needed. Na? Respiratory examination, there is no relationship. Then
Okay.
yes, rash itself we can examine. General examination, skin examination we can do as rash. There is blanchable, non-blanchable. I can notice rash distribution. Okay, cardiac examination for the complication like pneumotic carditis. Neurology you can give if you wish. So how can suppose that is scarlet fever? What is the management we offer?
So, scarlet fever, we will have to admit the child. We'll have to take blood cultures, assess the ABC, stabilize the child's ABC, admit the patient, take initial investigation, blood culture, and start on IV antibiotics, and take the throat swab as well. And
Okay, so management first, we know airway breathing circulation always we keep in mind child status, that is stable or non-stable, we keep it. Then supportive measures we are giving medical treatment like painkiller, calamine lotion or antihistamine for itching, antibiotic to prevent the spread of infections, oral penicillin if sensitive to macrolides. So remember that mainly supportive treatment like analgesic, IV fluids, proper nutrition maintaining, giving hydration maintaining, painkiller. These are any antihistamine if itching complaint. And for prevention of infection, we are giving antibiotic, that is penicillin oral if sensitive to macrolides. Then we are giving some advice like stay off nursery, school or work 24 hours after you take the first dose of antibiotics. So 24 hours after the first dose of antibiotics, and some medical advice will give first if not getting better in a week, like week going, but child is not improving, and after seeing a GP. If scarlet fever is chickenpox at the same time, and if ill again, weeks after scarlet fever go better, this can be a sign of complications such as rheumatic fever. If feeling unwell and have been in contact with someone who has scarlet fever. So remember that is we are giving main advice is our that is stay off the nursery one day after starting the antibiotic, and another is that scarlet fever, one of the complication rheumatic fever. So when the child after 1 week it is not improving or child improve but again becoming, that is a sign of complication of rheumatic fever. That is we keep in our mind, we advise this. And management is supportive, we keep in our mind. Oral penicillin we are giving, not IV dear, oral penicillin.
okay.
And
And
incubation period is
is this
and the incubation
notifiable?
hmm,
Do we have to
yeah.
notify the nursery and
No,
contacts?
Scarlet fever, I don't think notifications. Pertussis we
Okay.
notify, right? Isolation
Okay.
notification, pertussis.
Okay.
Um, incubation period is 2 to 5 days, and infectivity period 6 days before you get the symptoms until 24 hours first dose of antibiotic. If you're not antibiotic, 2 to 3 weeks after symptoms start. So like pertussis also, 2 to 3 weeks if not taking antibiotic. But if taking antibiotic, then one day. So this is all about scarlet fever. It also comes on exam. Thanks for your participation.
Thank you, doctor.